for then the work session that we'll have at the end of this meeting. So first I want to mention that I don't know how many of you knew that Annie was pregnant, our colleague from Burke, who's been so pivotal in all our work for the past year or more. And so in February, she had her baby, and this is a sweet picture of her newborn, and mom and baby are doing great. So just that way to introduce our new team member. Then we're going to do some updates on the work plan, the tribal technical work group, the assessment, measures, shared services, and then, like I said, go into the work session. So I'm going to move us on to the next slide and hope that you're all seeing the slides change. I'm going to check that view. And the background music was
hey, Marie.
blocking.
Marie,
yeah.
people who are not on hold can unmute themselves individually. And that way, the person who's on hold who made us will not be able to do that because they're obviously on hold. So I'm just saying, right. you can unmute yourself individually.
Got it. Thank you, Alan. That's helpful. I'm learning new things all the time about the webinar. Great. So you guys can unmute yourselves, and then you'll be able to talk. Okay. Anything before we get started that folks need to add to the agenda, or thoughts or questions? Or Scott, anything you want to jump in with here at the beginning?
No, you got it good. You got it covered.
Okay. Okay. So before we look at the work plan for 2017, I always find it helpful to just catch our breath for a moment and pause and look back and see remember what it is we did in 2017, because this committee has been busy and has been doing a heavy lift and a yeoman's job of churning out really deep and wide and important product here that's really moving this work forward. So just to take a moment to review that in 2017, the work that you guys did so much effort on and that Burke was so instrumental in helping support was the development of operational definitions. And in a moment, we'll look at another slide that reminds us a little more of the detail on that. And then publishing the functional definitions manual. We switched words, as we are known to do in this work, from operational to functional. And then designing the statewide FPHS assessment. Another, in parallel with all that other work, this committee weighed in and provided input to Burke about ways to collect the data and what kind of data to collect, advice on the technical assistance that LHJs would benefit from. A subset of folks participated in a beta test of the online tool, and then you guys were part of the preparing and rolling out to implement this in November. And then we also started at our last meeting using data from the Oregon assessment report to begin to get familiar with what it is we're going to see, what kind of data we're going to see from our Washington report. So I've got just a couple of slides that remind us a little more about all that work and where we ended up on some of this. So this is, you might remember this image. This is the image we used to describe the process we used in the operational definitions manual development. And what it illustrates is that in this first column here, preliminary, that based on work done in Oregon and Kansas, and then a host of materials that we provided to Burke from Washington, Burke provided drafts of each of the chapters for the operational definitions. And then those are the chapters that 9 different subgroups worked from and did 3 iterations of review and revisions to before then a draft in the next image here was brought to this committee for your review and your revisions and input. Once all that was done and packaged up together, then the final draft is what was published on the web page, and it's what filled out the content for the FPHS assessment. The reason that it's called the final draft is because Burke has been coaching us all along, since they've done this a few times now, that we learn a lot during the assessment process. And that is how we uncover areas where our language was not as clear as it could have been, or things are confusing and questions come in, well, did you mean this or did you mean that? And so we can use that input after the assessment is complete and the dust is settled, to then make a final set of revisions to the operational or functional definitions, and then we will have a final manual for that period of time. So just kind of a review of where we're at in that process, that we're really close to done, but we're not completely done on that yet. Does that make sense? Or any questions on that? Okay, I'm going to move us on. You might remember this slide as well. This one had to do with altitude, and this is one of those great opportunities where we can really see that the states that are involved in FPHS are getting a chance to kind of leapfrog off of each other's work. When we first started this work, Oregon picked up our definitions and framework and used it, and then they leapfrogged ahead because they had a legislative mandate to hurry up and do the operational definitions and an assessment. So you can see here just the illustration of how they had 7 capabilities and 4 programs. And when they started doing operational definitions, they came up with 40 functional areas and these 751 roles and deliverables. And one of our key goals was to not get that detailed, because that we all believe that was just a little too detailed and cumbersome for folks. So the slide kind of shows what happened in Ohio and Kansas. And then kind of looping back to the left side of the slide, what Annie had been coaching us on all last year was that we probably didn't want to go as detailed as Oregon did, but probably wanted to end up somewhere, you know, between 100 and 700. And so I was able to fill in here kind of where we ended up, and that we were able to reduce the number of elements, because you'll remember that in communicable disease and a few other places, you combined some of those things. And then we came up with the 350 activities that are under those elements. So overall, when I went back to this slide, I thought, wow, good work, guys. Nice job. Any questions about this concept or slide? Review and remember, anybody who printed out the slides, I rearranged these just this morning, so I'm skipping ahead a slide, I think, in your pack from what you might have printed. But I just wanted to tuck in here and remind folks that there is a tribal work group working all along in parallel here. And that Torney Smith and Susan Turner are representatives of the SOFO that were asked to join that work group to help be that bridge and help communicate the process you all have been through in the past many years, and should be able to share that information with the tribal work group and be a resource, and also kind of just link these 2 technical work groups back and forth. I also wanted to mention that kind of like this technical work group is represented on the FPHS steering committee by the co-chairs, Dennis and Scott. The tribal technical work group also has a representative on the steering committee, and that's the new DOH tribal health director, and her name is Tamara Fullweller. I have a hard time with her last name. So that's how we're kind of trying to stay connected and have those liaisons back and forth between the work. In 2016, when the tribal technical work group started, they spent the year doing a deep dive into the definitions and really beginning to ask each other, what does this look like in your tribe and what does this look like in your organization with the definitions? And really kind of got very exposed to all that nuance. And in the end, one of the things they decided is that the FPHS concept and definitions felt a little premature for tribes, and they felt they wanted to back up, step back, and first set up and establish communications with tribes about public health overall as separate from clinical services. So they spent 2017 exploring lots of avenues for doing that, including a public health profile that the National Indian Health Board is running, very akin to the NACCHO profile and the ASTRO profile. This is where then we came to all the LHA directors and asked for your input, you know, what kinds of FPHS services do you provide to tribes at their request? We did some data collection that way. And then they were preparing some key informant interviews and getting ready to stage regional dialogues with tribes in 2018. At the end of 2017, this work got put on hold because the liaison position at DOH was vacant. And so it's just been refilled with Tamara. So this group will get kind of stand back up this year and probably edit this work plan that is in gray here, but just wanted to make sure you were aware of that work. Tony or Susan, do you have anything you want to add to that?
Yeah, no, I'm fine with what you covered, Marie.
Okay, thanks. Okay, well now let's look forward to the 2018 work plan for FPHS overall. And this information didn't fit very well on the slide, so I sent it to you also as a handout for today. So you should have a Word document that has more detail than what's on the slide. But I'm just going to try to use the slide as a starting point, starting talking point kind of thing. So on this slide, the columns represent, the rows represent the kind of the two buckets of work that has to do with public health transformation. And really that is about, that's the idea that our whole purpose is to get away from running around every year, trying to pull numbers and stories together, and every year trying to reinvent our message and our ask to the legislature for money. I think Barry Kling was one of the great proponents of this idea. It's like, you know, we can't just keep doing the same thing over and over again. We're not very successful. We need to do something different. So rather, we aim instead as a governmental public health system to envision and describe the modern transformed public health system of the future. This is a long-term type of plan, not just a next session plan. And as a companion to that, then develop the strategies, both legislative and other policy actions that don't require legislation, that'll move towards this vision in a phased, multi-year and multi-biennial way. So this work plan with the seasons on it in large chunks begin to map out kind of the timing when that has to happen in order to be ready for the 2019 legislative session and future sessions. So this is really a very high level kind of work plan, but it's just to remind us that, you know, budgets get done in the summer and bills get written in the fall, and all this has to feed in on this kind of a timeline. So that's one of the main work areas of foundational public health services. The other one is the lower row on this slide called initial investment. That's the $12 million a biennium that the legislature appropriated last session. There's a lot of work going on under that to use this money appropriately, but also to learn from this experience and use the data from this experience to inform that public health transformation plan that we're all trying to put together this summer. So on this timeline, you'll see that this is kind of a reminder that, like we started last month, we can practice by using some data from the assessment in Oregon as a beginning way to start thinking about this. Later in the year, you'll see under the summer part of this work plan, we'll begin to have our own data from Washington from the assessment. But we'll also have quantitative data from, you know, how the money in Washington was used and what impact it might be having. We'll have qualitative data that's coming from LHJ work plans and reports. And we'll have fiscal data about how the money was actually used. And we will also have an evaluation of the demonstration projects that are happening right now. So we hope to have a good bit of all of that by summer so that the steering committee and with input from this committee can be using that kind of learning to say, how do we want to shape the system for the future? And then put that into the transformation plan. So looking at this slide, hearing that information, and or looking at your handout, what thoughts or questions do you have about the work plan? And if somebody's speaking, don't forget to take yourself off mute. Thoughts or questions?
Marie, this is Scott. Can you hear?
I can, yes.
Okay, no thoughts. I'm just trying to make sure the system was working because it's quiet.
Yes, it is. It's a little unnerving, so yes. I'll take a pause right here, partly to catch my breath, but also I see a number of people join the webinar, and the webinar does not display your name. So if you could open the attendee list on your little control panel, if you have joined but your name is not displayed. Could you identify yourself so I can also collect attendance here? And I'm going to try to make sure everybody's unmuted. Okay, maybe that works better. So anybody whose name is not showing up on the attendee list here, would you identify yourself?
Marie, I don't know if you can hear me. This is Dennis.
Hey, Dennis, welcome. Glad you're here. Who else has joined?
Dave Wyndham's here.
Great, Dave. Good to hear you. Anyone else going to speak up? Okay. Okay, well, I will keep this moving forward here. We are recording this today. And I want to remind people not to put your phone on mute. That happened earlier, and it made the sound of audio difficult. So, okay,
I don't think you want to put the phone on hold. Mute is okay. They don't want to put it on hold.
You're right, Ellen. What would I do without you, man? I could not run these webinars. Thank you. You're my right-hand guy. All right. Do not put the phone on hold. Only use mute. Okay, moving on. Let's see if I can get my slides advanced. So, Allegra, I was going to ask, could you jump in here and give people the update on the assessment process that this committee's been so involved in?
Absolutely. So thanks to everyone who has completed your assessment. Much appreciated. Marie mentioned the definitions manual earlier, and many of you put comments in and sort of your interpretation of the definitions or any questions you had about that. So that was greatly appreciated because I think that will be helpful in finalizing those definitions. We had a goal of all tools being returned by 1/16. We knew that was pretty ambitious, and we have had a number of, kind of negotiated extensions. We are almost complete. I think we have one that we expect to receive, but that has not stopped us from reviewing the assessments we have, and we are starting the data validation process soon. So one or two of you on the call may get a reach out from us at Burke, just making sure that we understand fully what you may have entered. If there's data that shows up an outlier, or we have a question about it. I think we've tried to be clear all along. We're not going to change anybody's information without having a conversation with you. So that's in process. That's going to sort of compress, I would say, our analysis period a little bit. But, like we all do, we tried to sort of plan for what would be the ideal analysis period, and we are going to have to compress that, but we will be able to do that. So we are hoping we'll have some preliminary results to share, possibly by the next meeting. We do want to make sure that we're giving kind of final information and not any information that's going to change. So we hope to share that soon. But again, I really appreciated everybody's help in getting this complete. Understand that it was a big lift, and really hope that it can provide a baseline and a platform to work from going forward that creates, that doesn't require as much effort for everyone.
Great, thanks. And Jamie, do you have anything you wanted to add in here?
Yeah, just to, again, thank Allegra and her team for all of their work and continued work on the assessment. And then I also shared a calendar invite with the LHJ directors to convene and discuss the FPHS assessment kind of as a debrief. I asked them to share with their staff that participated in the assessment, so that if there was a different point of contact, that they also be included in that debrief. That is next Thursday, the 8th, from 8 to 9:30. We'll kind of discuss the process of assessment, what it was like for the LHJs, the content that was included, the challenges of the assessment, but also the benefits that people felt the assessment gave them, communication and rollout, and then kind of our next steps and expectations that we as LHJs have for the FPHS steering committee in terms of disseminating assessment data and things like that. If you have not received that calendar invite, either via myself or the LHJ director, please let me know, and I will make sure I get you all included in that as well. You can either just let me know now or shoot me a quick email that says, forward me the FPHS debrief invite or something like that. I think we have about 25 people who've accepted the invite, so it should be a good discussion.
Great, thanks. Any questions for Allegra or Jamie on this? Okay, thank you guys. Okay, the next slide here is just a review of the measurement work that's going on for the $12 million. I'm not going to drill down or spend a lot of time on it. I did attach to the materials for today's meeting the 3-page document that describes a little more background on this, and so you'll have that, and I'm happy to answer any questions on that. The main thing I just wanted to describe is that when it comes, so the qualitative data is coming from LHJ work plans and reports, and a summary of the initial work plans is on the FPHS webpage. And if anybody wants to find that and has any trouble finding it, let me know and I'll send you a direct link to it. The quantitative data, we are getting the baseline data right now from DOH programs, and within the next few weeks I should have the set of baseline data, and we're using the first half of 2017 as baseline and comparing that to the first half of 2018 because we had to time this around when the money went out and when it is we have to report back to the legislature and things like that. So this will at least be an initial swipe at doing a baseline and one comparison set of data. For the measures that you've seen before and that I tried to summarize here on the slide and are in that handout. We are in the process right now of planning the evaluation of shared services demonstration projects, and we're going to contract with Burke to do that for us so that we have an outside third party that's not state or local and somebody who's well versed in this work. Just seems like it will really lend itself to folding into this whole picture of measurement. Do you guys have any thoughts or questions about measurement overall, either from this slide or from what's in the handout or anything else? Okay, you guys are being super duper quiet today.
Marie, this is Mary Gels. I had a question about the reports from LHJs. I had on my calendar that there was going to be some sort of initial report due in like January. I haven't seen anything more about that.
Great question. Thank you for raising that. And I've been working in the background with our contract staff and with Jamie and others to make sure that we shape this right. And I hope that within the next week or two we'll be sharing information. But what was in your original consolidated contract was the best that everybody could imagine and write down back in October last year when we were trying to get this money out to you as fast as possible. So the January deliverable time stamp, in essence, in that contract was an estimate about, we would need information at some point, and that was as much as we knew at that time. We were really thinking about the baseline data at that point, and so I've had a few counties contact me and say, yeah, what about this report? And it's like, taken care of. DOH is providing the baseline data. The DOH programs will be able to pull from all those existing databases these quantitative measures, both pre and post, basically. So that stuff's being taken care of. What we are going to be doing is, and we will let you know way in advance, is at the end of the first state fiscal year, so in June, we're going to ask if you would send a simple one-page report on how you actually spent the money, the previous set of money, and then the new work plan for the next batch of money. How do you plan to spend the next state fiscal year's worth? Trying to keep this as simple as possible and yet still get the information that we all need to think about our system and then we need to report to the legislature. So does that answer that, Mary?
Yes, thank you.
Great. Any other questions on this? Okay. Our next update is about shared services demonstration projects, and I'm going to hand it over to Jamie for this.
Yes, thanks, Marie. I just wanted to give a brief update. So at our last steering committee meeting, which was the 21st of February, so 2 weeks ago, 1 week ago, I don't even remember. But we did have our shared service demo projects do a brief presentation on their project as well as kind of where they're at. It was really well received. They did a great job. So just to review with you all, we have the 3 demonstration projects. The first one being the provider resource website, making data and other information available to local healthcare providers. So Tacoma Pierce is leading that effort and has 2 counties participating. And that one is really just kind of getting off the ground. A lot of work has been going on behind the scenes for Tacoma Pierce, really setting up the stage to move on to that next phase. There's another project over with Spokane leading the way, and that one has to do with the epi services, supporting communicable disease, and then also assisting local health jurisdictions with conducting their community health assessment. We have Adams, Lincoln, Northeast Tri, and Whitman participating in that one. And that one is really great. Stacy and Susan both kind of gave an overview of their different parts of that project, and it was really exciting to hear how that one just really took off and ran and took off running a little, maybe even too fast, but they're doing a lot of really great work too. And then we have a TB response support program with Public Health Seattle King County leading the way, with all local health jurisdictions eligible to participate as well. And that one has been very interesting to look at their process and very deliberately setting up and purposefully setting up a program and a network so that it is a statewide, very innovative new project. So the presentations were great. The steering committee asked a lot of really wonderful questions. I've also kind of provided a summary to the WASALPO board. They were very interested in having the demonstration projects do a presentation to them as well. So in one, we floated the idea of doing kind of a webinar that the demonstration projects could do a presentation. We also floated the idea of doing something in June. There's a lot of, I think, interest in just sharing these projects with local and state partners, and just kind of spreading the word, sharing best practices, walking through challenges, things like that. So we haven't, figured out what would work best, either a webinar or a presentation or perhaps both, but we definitely want to, in the next few months, increase the knowledge of these demonstration projects in one way or another. And that's kind of where we're at.
Great, thanks, Jamie. As I look at the roster for this committee, I'm noticing that each of those 3 lead counties are represented on the committee. Dennis Torney and Chris Schuler and Chris is on the phone with us too, yeah. And then there are 10 other LHJs represented on this committee. I'm not sure exactly who all is on the call today with us, but I just want to take a moment and say, so for the non-lead counties here, do you guys know about this TB project? Because that is a shared service demonstration project that is for all LHJs. So you guys aware about that one? Are you guys hooked in with that? Can you comment?
This is Mary Gels, and I know nothing about it.
And this is Regina. I know about it, but I haven't heard anything about what's happening.
This is Susan in Kitsap, and MASA reached out to us and is working with our clinic supervisor to arrange a visit to kind of do a needs assessment.
And this is Vic Jefferson, and I checked with our CD lead and Dr. Locke yesterday, and both had heard from them, and they have also done a reach out to wanting to come and meet with us as well. So, but the reach out was to the health officer and our CD, our communicable disease lead.
Great. Okay.
So this is Regina. So it's possible they did reach out and just nobody told me. That's possible. So I'll check.
Great. Anyone else? Any other LHJs that are with us today? David, what about you?
Yeah, same thing with Regina. If they contacted us, it wasn't me. It was through our CD folks. Yeah. Other than that, we've had very little to do with it.
Okay, might be something to check in on. And Dennis, I'm thinking you're with us on the phone here. There's probably some intel you can take back to your folks.
Yeah, this is Dennis. So I'm happy to take some of that feedback. What I believe has happened, and I can confirm this, is that the reach has been to all the health officers in the different counties, or the ones representing the different counties, and to CD folks. And in the process of doing an assessment about what the needs are for the programs and how we can be responsive. There's kind of a two-part effort, just if I could just take a quick moment. One of them is really to provide any technical assistance and support to programs, because we realize this is a local response, and what role they would like us to have. We want to honor that we're a decentralized system and those authorities are within each of the counties. So really trying to get a good understanding that we don't step on toes in how counties want us to work with them. So there's a needs assessment going on, working through the health officers and the CD teams across the state. And the second part of it is to also provide some education and training opportunities for providers and folks who are working within the TB programs within each of the jurisdictions. Some of that work is going to be done as a continuation. We've had a lot of success working with the Department of Health, really being the main drivers in it, and the University of Washington around TB Echo, and Scott can really say more about that. That's his area of expertise more than mine. And how do we build on those successes and continuing to provide ongoing education and support to local responses. The third part of the leg is really specific about if you need help in a response, that we would deploy a team to come and help if that was something that would be beneficial. We've had our first request to do that in Spokane, and sending out a team over the weekend. They have a TB situation in the Marshallese community, and we'll be doing some screening over the weekend at a Marshallese church with about 100 folks and doing QuantiFERON as part of that testing. So it's our first example of where we've actually done it deploying. And so we're kind of building this in what works best as a state response and how we can be supportive of that. So more to come if you haven't heard anything, and we can certainly get some more summaries out if it's helpful.
Hey, Dennis, this is Jamie. I was wondering if you're okay with it, if you could forward me the email that Masa sent out to the health officers. I'll forward that on to the LHJ directors just to make sure that they've gotten it. And that way you might have a little bit more of a response too. So if you want to share that email, I'm happy sending that out as well.
Okay, thank you, Jimmy. Yeah, I'll reach out to Masa and we can forward that on to you.
This is Mary again. I would say that it's very unlikely that Dr. Edstrom got something that he didn't mention to me, and I'm really the CD contact for our county. So should we be contacting her if we haven't heard anything? What's your suggestion?
No, I can certainly. Mary, what county are you with?
Pacific, like
all right,
the ocean.
I'll let Masa know. We can do a reach out to you specifically, but it sounds like also Jamie's going to be sending something up to the administrators.
Yeah, Dennis, this is Torney. Just thanks so much for your support.
Yeah, you're welcome. Thank you.
Great sharing and coordinating there, guys. Any other thoughts or questions about the TB project? And then I want to pause and also see if Torney or Chris Schuler have anything they want to add on about the work their counties are doing and the other projects. But anything more about the TB project? Okay, Torney, do you have anything more you want to anything additional you want to share about the work your LHA is doing with the 4 surrounding counties?
Just that I think it's going incredibly well. I think the counties have appreciated our ability to have the EPI capacity to help them do their assessments, and it's progressing very well.
Great, thanks. And Matt, are you on the phone by chance? Matt Chance? Doesn't look like it, okay. Okay, Chris, anything you want to add from Tacoma Pierce?
This is the project we're just getting started. We had some, I think we were about a week behind on our technical piece getting set up, but everything seems to be running ahead pretty quickly right now and getting the healthcare provider list out there. Sharon Plummer is the one sharing information, and if you're not getting the information that you want, contact me, contact her. We'll make sure that you get the full update. But with I guess a brief technical hurdle at the very beginning, we're back on track on that.
Great, good work. Okay. Okay, cool. This is just really exciting work. It sounds like it's really taken off. Okay, I'm going to move us on here to the next set of slides. So now we're going to kind of start into our work session for today. We have about 8 slides here on different information about displaying cost data. And the first thing is that, again, kind of like we did at the beginning of today, I want to take a moment and look back on some of the key work this committee has done, because this committee has been the workhorse and the pivotal point for doing all this costing work in Washington thus far. And then the latter slides in this little set here are be looking at information from Oregon and how it gets displayed and things we might be able to connect with data in the future. So let's see, I think the first slide here I have is that other than the red circle on this might look very familiar to many of you. This is from the initial work the technical work group did back in 2013 and 2014 to estimate the cost and the gap for doing foundational public health services. So let's walk through the slide first of all. And that's that here on the left column, we've got our foundational public health services programs. And I want to take a minute and point out that back then, we lumped together all the foundational capabilities, because when we did this work back then, using a sample of 9 LHJs plus DOH, we weren't sure that everybody would be able to sort out and divide up their costs by all those capabilities. So we went ahead and lumped them and then did the 6 program areas. So that's one of the things that's different about this display than the way we do our work now. Then you'll see in the next column is kind of where the data came from, LHJs or DOH. Again, using the 9 sample LHJs, what Burke was able to do with all their methodologies and analytic capabilities was extrapolate, make sure we're really, counting this stuff right. And then also let's remove any federal grant revenue that seems really shaky. And then that then produced the gap. I'm going to move my screen here so I can see this. So that produced back then the famous, or now kind of infamous, $100 million gap a year estimate in, about what was needed for FPHS. What I did on this slide is I circled the communicable disease piece of this as one set of numbers we can track through the next set of slides. There's a lot of numbers here, and so I think it helps sometimes to focus on one set to compare. I also think it's interesting that back then when we estimated this, we estimated about 11.1 million a year gap in communicable disease. So that's kind of interesting to be able to compare that to the 12 million a biennium we got from the legislature this round. So I just think it gives us a point we can compare. Regina, some of us have been through this whole walk, right?
This is Alan. I'm not sure all the numbers, I don't want to get into the weeds here, but I'm not sure all the numbers add up, unless my math is crazy.
Okay. Well, we're not going to get into those weeds right now, but that's a good to know. This is information we published, and it is on our webpage to this day in the technical reports. So just because part of what I wanted to revisit today is that as we go forward, we have a track record where we have published numbers And so that's something we're going to have to keep in mind as we go forward. So what happened next chronologically was that in 2014 and 15, we had the policy work group of elected officials that met monthly for a year for all-day meetings. And their major assignment was, A, does this kind of make sense? You know, B, do you kind of get how we're doing the cost estimation? And C, your task is, how should this be paid for? And that was the setting where the conclusion, there were a number of recommendations made, but one of them was that if foundational public health services need to be everywhere, and they need to be pretty much the same everywhere, pretty much sounds like a state responsibility. So that's kind of where we came to this part of our model development, and really represented a shift in trying to provide some clarity to funding roles. So this policy work group recommended that foundational public health services should primarily be funded by state funds for things that don't have a fee revenue attached to them, whether that be state or local. We have licensing fees we generate at the state, like you guys have your environmental health fees, and that don't have a solid federal grant mechanism behind them. Like we have the public health lab is largely funded, it has a lot of funding from federal, it's very stable, and we're not looking to replace that money with state money at this point, because I think we got a big task ahead of us just filling in what's needed right now. So with that shift, after the policy work group, then we had to finish the math, 44 million a biennium. So that represents 11%. Wait a minute. So I'm sorry, I'm getting ahead of myself here with this red font. We'll come back to that in a minute. People understand, at least in concept, why we switched from the gap to this funds needed. Questions about that? Meanwhile, I'm going to switch to this next slide here. So
Marie, this is Allegra. The only other change I think that happened in the 2016 plan was that in addition to adding updated information from King County, we also were collecting information from the State Board of Health.
You're right. Thank you. Thank you so much. Great. Let's go to this next slide, which provides a summary view of these two very involved tables we've just looked at. So this is the track record part that I wanted to us to help remember. So in 2014, so what happens is I have a column for annual numbers, a column for biennial numbers, because we tend to go back and forth. We're kind of multilingual here when we speak our numbers. So in 2014, we have this $100 million gap, which translates into $200 million a biennium. In 2016, when we tweaked the math a bit and switched from gap to additional funds needed, which would be a bigger number because it's removing some of that local money that you guys are using already to pay for some of the foundational services that are going on, and to pull that out and say, no, we need state money to replace that. The number's a little bit bigger, 156 to 172 million, or than the biennial version of that. And then at the end of this assessment work we're doing right now, come summer, we should be able to fill in this next row about saying, okay, now that we've collected fresh data from all 35 LHJs, DOH, and the State Board of Health, and are using our most current version of definitions, what do these numbers look like? So just wanted you to be able to see that in context. The other thing is that the red font is following through that communicable disease amount and showing kind of what 11% of the gap versus 11% of the funds needed would represent. Questions about this so far? Are you guys all blurry-eyed at this point? Okay, well, let's now take a look at Oregon's data, and then we can always go back and forth between the slides if needed. So this is, and Allegra, please, as always, jump in if there's something to add. So based on their FPHS assessment, which they did in 2016. Is that right?
Yes.
Okay. This is the summary table of their costs and their, in essence, their gap that they came up with. It looks very similar to the way we displayed data back in 2014 in that earlier table. Here are their foundational programs at the top, and then their foundational capabilities at the bottom. You see they're slightly different than ours, but pretty much very similar. And then the columns are the total estimated cost, and then the current spending. Sounds kind of familiar, huh? And then the cost of additional increment of service, in order how much more would it cost to bring this up to full implementation. I added the red circle to this table to again focus our eyes on, for example, here's communicable disease. And they're saying their gap in that is about almost 13 million a year, and that represents about 12% of this total. So I find it reassuring that it looks pretty similar between the two states. Ours is 11%, theirs is 12%, and it just kind of gives us an idea of kind of how these two states look together. They are smaller than us. They have less population than we do, but still kind of proportionally comes out this way. This is a pretty, I think, clear and a reasonably understandable way to show these costs all rolled up like this. It's one of the ways we could look at, showing our data at the end of our assessment process. Any questions on this from Oregon? Okay, the next couple of slides are really just kind of experimenting and considering what all could we do with data from our assessment. But I am using the Oregon data here. So that same numbers chart is at the top. CD is still circled. And below, those of you who were on the webinar last month will recognize the checkerboard diagram from that work. Let me walk you through that one, just a refresher. The rows are each of the foundational programs on down to the foundational capabilities. The columns represent agencies. So there's the State Health Department, the large LHJs, and on down in size. And the color coding drawn from all that assessment data represents the degree of implementation of each of these FPHSs. So dark blue is best, light blue is some implementation, and on down this color scheme. So one of the things I'm wondering is when we look at the Washington data later this spring and into the summer, what might we be able to do when we look at a gap? This is Oregon, so I'm going to use the word gap, 13 million a year. And then we look at, it would take 13 million theoretically to turn all of this dark blue. And maybe compare that to some of these other rows. Let's move on to look at some of these other slides to kind of flesh out that idea. So,
well, and Marie, if I can just jump in quickly,
yeah,
I do
please.
Want to just sort of give some context. You may have covered this last month on how Oregon used, sort of what we're referring to as the checkerboard, and it is very much an internal exercise, I would say, in that, of course, this is self-assessment data, and it was arrayed this way to just see, was there anything that jumped out, so that it was so clear that, for example, it would make sense to put, all of the, any new additional resources must go to CD, because if you looked at CD and it had been limited implementation or minimal, in a straight row across the top, it would have been a clear indicator. In fact, as you can see there, what you get is a very uneven system, but without a clear indicator that, if you only had limited money to spare, there's an obvious place to put it.
Yeah, great. Thank you, Allegra. Any thoughts on that kind of stuff? Folks on the phone, or questions or ideas? These kind of imagery set next to each other might generate for you? Okay, well, let's experiment with a few others here. This one should look familiar from last month. First, let me just walk through the diagram. Here we've got communicable disease, and this is one of the elements. It's communicable disease surveillance, and then some of the activities under that. So this is fairly detailed. And then there's two different ways that the data could be displayed. And the first set right here has to do with by agency. And so if we look at the summary level here at the top, communicable disease surveillance, and see that 9% of the LHJs have it significantly implemented, 47% partially implemented, and on down the row. And then compare that to the set of data that's over here on the right, that is population-based. This represents the percent of the population covered by these services. And so you can see it's slightly different, that 15% of the population is got significant access to these services, and then 51% is partial implementation of the services and on down. So it just shows that in the data that comes out of the assessment, we can look at it either way. We can keep looking at it both ways to see what it tells us and what we can learn. So then, remembering the cost of data from Oregon, that all of their CD work, they were saying there was about a $13 million a year gap. What's below here is one of their 4 components. So it might be that we could use data to inform how we invest money or how we prioritize asks or things like that. I'm going to go on to the next slide because I think it helps show the comparison a little more. So this is back up at that element level of the definition. So here's communicable disease control, and here are the 4 elements: surveillance, investigation, intervention, and evaluation. Below that is environmental public health and the 3 elements of their definitions underneath that. The data here is using that population scale. Partly I picked it because it shows, you can see some real differences in this data. So if the CD gap estimate was 13 million a year, and this is what implementation looks like over here, we could use data to help us direct an ask or direct an investment, and we might be able to make choices and prioritizations among the FPHS services. So down here we've got EH, where they estimated about a $14 million gap, and it looks like we've got some areas of great need here. So just some of the ways that we anticipate this spring to be able to be using some of our Washington data about what all people who contributed to the data have said about their level of service, as well as put that with the costing data and be thinking about how do we set up this multi-year, multi-biennia phased plan to get to a fully implemented system of FPHS. So that's the slides that we have to share with you today. What kinds of questions or thoughts or ideas does that spark for you guys?
This is Jamie. One thing we talked about very briefly at the steering committee was the color and just paying attention to the color and I'd love to get the technical work group's thoughts on that too. That we know blue is great and orange and then that really dark orange is not so great and bad. What about kind of that middle, that lighter blue color, just as a visual that maybe addressing some of that little intricacies to really hit home the point of, I'm looking at environmental public health, that first line where it's 1971 and 9, and that big blue bar, and really wanting to make that big blue bar dark. How to better visualize that light blue bar? Because looking at it from a lay person view, it's like, yeah, not too bad, but we know that that's not what that means. So I think just paying attention to how colors are perceived might be important.
Yeah, great reminder, Jamie. We had that discussion. Any thoughts, folks? And part of the conversation at the steering committee too was, again, the first use of all this data is for us. We're trying to learn about our own system, but even so, it helps if the colors communicate the important messages to us. then once we figure out the plan and the phasing, there will be a lot of work done on by a communications work group to package that for external audiences and for advocacy. But even as we use this data, and there are things you can think of, because we have a chance now to be, as we play with Oregon's data, to be giving input to Berk about ways that we might want to be able to see or use our data.
Marie, this is Susan. This is just totally off the top of my head. I didn't have this response when I looked through Oregon's report, but when I was looking through these slides, in my simplistic mind, I like the streetlight approach. And red is clearly bad, and green is clearly good. We might need some gradations because we have one more category than that, but that's just off the top of my head. That simplifies it for me because I don't have to learn a new color scheme. I get that color scheme.
Great. Other thoughts?
This is Vicki, and one of the things that, and I guess it's more a caution than a thought. I think you're right, Marie. We have to think about how we display and how things might be perceived. But one of the concerns, or just the cautions, would be that as we prepare for external utilization and advocacy, that we not end up with an unintended consequence that turns funding requests into categorical revenues. That that we recognize that we're talking about the overall system and levels of gaps, but that we figure a way to also talk about the fact that this is an amalgam, and each local health jurisdiction's picture might be a little bit different in terms of level of funding need in a particular area. And so I guess bottom line, that there's some way to maintain a little bit of flexibility as we move forward with a funding ask.
Great, that's an important point, Vicki, thanks. And the steering committee is definitely of like mind. Part of the thinking is, I'm gonna jump back a couple of slides here. Let me, so I don't make you seasick. There we go. Let's jump back to this summary one, that whatever our number comes out to be at this year, 2018, let's just use the 2016 number right here for right now. I think the steering committee is pretty clear and confident that they don't expect the legislature to ever produce that amount of money in one year in one ask, which is part of this multi-year, multi-biennium phased thinking. And so I think, while trying to avoid or minimize a categorical approach to this, what conversations that are coming for the steering committee in the coming months would be, how could we use our own data to be ready to make a strong case to legislature that, this year in 2019, we're asking you for funding for X, CD or environmental health or chronic or something. And we'll be back next year. We're going to be asking for the rest of the money in Y and Z, but trying to do that phased approach. However, there's no answer yet about what that looks like or how it will be segmented, but people just feel it's really would be pretty unsuccessful and would be very unlikely to ever get this giant wad of money all in once. So that's part of the dialogue and using data like this and why we're talking about this stuff. But I think that I know that everyone is very like-minded, Vicki, in not wanting this to become categorical, but also trying to make it definable enough to get the buy-in of the legislature.
This is Regina. The one thought I had is there's so much data and there's so many ways you could slice and dice this. I was thinking it might be a good idea to really think about what questions do we want to raise or answer, and then based on that, how can we display the data to help us explore that area? Does that make sense?
Yeah. Yes.
Yeah, because I mean, just looking at these different slides, I mean, they're good and they do provide information, but I'm not really sure that we're looking at it in a very logical way. So what is it we need to know, and then how can we display the data so that it makes it easier for us to get the answer?
Yeah, that's great. And so I'm going to put you back on the spot, Regina, but also ask everybody else this question. What kinds of things do you wonder about our system? Because we all work in our own agency, right? I work in my own agency, and you all work in your agency. And we don't actually get to see, it's all the blind men feeling a different part of the elephant, right? But if you could really see the whole elephant, what would you want to know?
This is Chris in Tacoma. I haven't really formed my thought yet on this, but there are a lot of connections between some of these that are foundational capabilities versus foundational programs. And what I think in a system like this, if I try to put myself in someone that's making a decision, I'm going to look at these line by line. I'm going to a la carte pick which ones I feel are the most important and fund those separately. That's a danger with something like this. But there's also some interconnectedness to things like assessment and epidemiology that plays hand in hand with communicable disease control and many of the community partnership developments across the board, where the impact of some of those, there's not a direct tie. Maybe a communication plan of how to educate the folks that are looking at this data that cutting this has a broad impacts across our capability of our foundational programs. And there's some of the nuances that could be lost without a little more background information on this.
Yeah, that's great. And the steering committee also, I think, is thinking along the same path, and that kind of like we did with the $12 million that the legislature granted this round, saying that the money is for CD and the capabilities that support that. Because I think one of the other things that's going on that people are thinking is that it's unlikely the legislature would just fund capabilities, because it's harder for them to wrap their head around that. But somehow incorporating the capabilities with each of the program asks kind of thing. So trying to strike that balance. And so for decision making, if you guys have, I don't know how this will roll out in the next few months of dialogue, but I think in a variety of meetings, steering committee, technical work group, with SALFO meetings, different things, people are going to be looking for input on this from public health leaders. What other kind of information would you need if you were going to advise the steering committee, okay, if I'm looking at Oregon numbers here, and they say they need 106 million, if we weren't going to ask, if somebody wasn't going to ask for 106 million first crack, and they were going to ask for some subset of that, what would you be looking at, or what would you want to look at to help prioritize that?
Yeah, so I was thinking a little bit more about what I was saying. This is Regina again. So it seems like what we're trying to do is assure that we have an equal level of service, right? Foundational service across all of our jurisdictions. And so if I were looking at the data, just as you were just describing, I think we need to really figure out what are the most important services, because we're not going to ask for it all at once, right? So we'd want to decide that, and then we'd want to look at where in which of the services or which of the areas do we have the biggest gaps, and then how is that gap distributed across the jurisdictions, and then how can we most equitably distribute the dollars that we will get to help fill the gap. So those are some of the questions I'd want to answer, and I think you can arrange the data in ways that will help us, will give us a better visual picture of that.
And this is Vicki. I think the other thing that sort of compounds it a little bit is we have the construct is that the state would pay for foundational services and capabilities, but if the allocation, like it was this year, and sort of an arbitrary amount that doesn't specifically address not just the gap between where we are currently and where we need to be, but the concept that we would be, CD, for example, that we would be redirecting local dollars someplace else and state dollars would pick up those responsibilities. But the state has never given us to date enough to do that. So we have this sort of hybrid that continues us kind of down the path that we're on. And so the answer to what I would need, for example, would be different if I knew I could pull all of my local dollars out of CD because the state was going to fill that dollar amount for me, and I was able to put those dollars into the additional important services, or how we've envisioned it. And it begins to make it a little bit harder to explain. Part of the goal of putting the money into communicable disease and immunization and the capabilities that support them is that we'll be able to show improvement. But the reality is there's still a significant, I'm guessing in most jurisdictions, a pretty significant amount of local dollars that are still going into those programs. And so I think we have to pay attention to how we talk about that as well.
Yep, those are great points, Vicki.
Marie, this is Alan. I've got a question, and I hope this is not off the point, but I was thinking about the original slide you showed when we first started this conversation is that I guess we're going to have something for the legislature by November or something like that. This stuff, including these boxes with all the colors on them, and the conversation we're having is complex enough, even for us on this call to understand. And I'm wondering, I know we're the technical committee, but is there a communications committee or something that's going to take all these data, which are pretty complex, and translate it into stories for our legislative audience so they know if we don't fund this in simple words, what's likely to happen or not happen? Because if we presented this to a legislative group, I think their heads would explode.
Yeah,
my head's almost exploding by being involved in this, let alone a legislator.
Exactly. Good question, Alan. So on that is that there is the Public Health Roundtables Subcommittee on Communications. It's been really the de facto communications committee for FPHS for the past couple of years. And they stand ready and on point to take up once the Public Health Transformation Plan once we all, Technical Work Group and Steering Committee and all, develop the Public Health Transformation Plan and the strategies about what the different asks will be over the years. The Communications Committee stands ready to repackage that to help us achieve that goal through communications.
Yeah, well, I'm thinking that we need to do that sooner rather than later, because that should be going hand in hand with the analysis that we're doing. I'm concerned that we're already into March. I know that I spoke to Senator Cleveland's staff, and they're really interested in hearing something this summer, the latest, or at least, I'm just concerned that the timeline is going to get ahead of us. And I think the trickiest part of this is really going to put this into language and stories that the legislators will understand.
So if I can weigh in for just a second, Alan, I have some of the same concerns, and we talked about this at the steering committee just a couple of weeks ago. The meeting that we have coming up with the steering committee in March is really talking a little bit more about the strategy and going forward. But just to share with you some ideas that came forward from the last meeting was, we know that the data alone is not going to be a compelling enough story to really move legislators. Because I agree, I think that some of this will make their heads spin. So things that we talked about was how do we kind of put a strategy together that encompasses not only the data, but return on investment efforts, risk, if not funded, what is the risk levels that we will be at around some of these practices or some of this work in our community. And then the other one is really about the story gathering that helps support each of the data points that gets to a better place. And so I believe, if I'm not mistaken, that the March meeting is dedicated in the steering committee to look at all of those particular pieces and develop the strategy that we need to move forward to the legislature, that the data points are only one piece of that work.
Yeah, I think the data point should be the last piece. I think the data point should support the stories rather than the other way around, because if we don't start with the stories, we're going to lose them after the first few sentences.
Yeah, absolutely. This data is not intended for the legislature. This is intended for us to make decisions about which stories to tell and which things to ask for when. Yes, the March steering committee meeting is going to have the communications folks attend and participate in that conversation. All good points.
This is Vicki again, and I guess one of my questions would be, do we know that the legislature supports this concept of of foundational programs and foundational capabilities, and the general consensus that foundational is a state responsibility and other important services is a local responsibility, and it's a combination of the two that create the public health system in this state. Do we know that they support that? Because thinking about my legislators, for example, I could see them, if they support the concept of these foundational programs and foundational capabilities, what they're going to ask me is, okay, so what do you need in order to do this?
And this is Dave. I'll pitch in on that a little bit. So, and you've got legislators who understand the concept of foundational public health. They like the idea that we look at the spectrum of public health and we decide what are those things that are foundational. We focus on those. What they are not comfortable with is that money would all come from the state and the locals would lose control. That's one of the things that pops up again and again. Also, as we put this stuff together, we need to decide what is the sale going to be here. Are we going to sell ourselves piecemeal, like Vicki was talking about, and we ask for a piece of this year, a piece of this next year, when really the design of this was to have a state-funded system? Or do we just go for the state-funded system and see where that takes us? Because if we have mixed messages, we're not going to get either of those things.
Yep, good points. More conversations evolving on that all the time. The steering committee is definitely going to be dialoguing about all that. Any responses, other responses to what David was sharing, or other ideas? This has been a really helpful conversation, I think. I've been taking notes rapidly here. I'm sure Allegra was also, and Jamie.
Yeah.
And so this is exactly the kind of conversation we are excited to be having with the technical work group and the steering committee. And again, we are looking to also find ways to bring this kind of conversation into WSALFO, the broader WSALFO community, because the goal is that we all invent this together and be able to carry this forward together in this phased, multi-year way. And this is we've been on a long journey thus far. We yet have a long ways yet to go. So we definitely want to be able to do this together. So because I'm not hearing any additional comments, I'm going to move us towards wrapping this up. But I will pause and just say, any last comments or questions or things that you would really want to be learning about in the next couple of meetings?
Well, Marie, this is Torney. Just thinking to the last several comments, I think it's important, though we know this information is for in-house as opposed to those folks at the legislature. It feels complex And if we haven't had the time to really study it, I think we will tend to confuse people. So whether it goes back to Susan's comments about colors, red, yellow, and green versus what we've done, or, David's comments just a moment ago, I think we need to continue to think about how we simplify this as much as possible as we present it.
Great. And I'm going to jump in and say, I'm wondering, and Dave, I'm going to reference one of your points here, so I'm not sure if you're going to have something to add to this, but I'm wondering if this venue or if there are other venues where folks might want to discuss more this whole idea about funding, who funds and what the implications of that are as far as kind of power and control and things like that. Or maybe those conversations are happening in WSALFA already, or any more thoughts on that kind of piece of the pie?
Well, there are conversations taking place about that, because there are concerns. I have concerns in that if we go to the state-funded system and the state says we'll fund foundational public health, locals, you can continue to contribute, but we'll shift that over to additional important services. Well, my county is going to define additional important services as another sheriff's deputy and another car. So I think we might wind up on the short end at the end of all this, depending on how this fleshes out. And that's a concern that I have.
This is Dennis, and I appreciate that insight, because I think you have a different perspective from where you sit and where you have sat, Dave. I know that the work I've been doing legislatively, either through WSPHA or through different roles that I've had, is it seems when we get to the legislators and we talk about money and funding the public health system, there always is this debate at the state level, at least, with the legislators, is really as who is responsible for funding public health? Is it a local responsibility or a state responsibility? I think the one good thing that has moved us forward around some of these conversations around the foundational public health is we've kind of put our stake in the ground and saying we do think there is a state responsibility, and we'll define what we think that is, and that's really around the foundational services. And everything that is driven by a local need or some of the programs in order to support this work going further is really a local responsibility. So I think it's helped us move us forward in the conversation. And I do think that there is getting a gradual support, at least with some legislators, of really understanding what the state responsibility is versus what a local responsibility is.
And I also think it's important to remember that we're not eliminating the local fees, and the local fees are set by our local boards of health, and that's a whale of a lot of money specifically supporting foundational public health services as well. So it's not like the locals have no skin in the foundational public health services game.
But we also get county general fund, and I think when we use the word foundational, so I think our messaging is really important. So when we use the word foundational, and the state is going to fund foundational public health services, I think I hear David saying is that, well, that's a message to local boards that, well, the state's funding foundational, so the stuff that we're talking about at the local level isn't really that as important. I'm thinking that we just got to be careful with our language and our messaging about this, and this is, the public health system is a partnership between the state and local government, and I think we just need to be careful about how we talk about it.
I would definitely agree with that.
Hi guys, as I'm hearing this conversation, and I love it, I'm wondering if it would make sense to do a brief kind of brainstorm session with the Public Health Roundtable and the Steering Committee and the Technical Work Group, and just outline the big areas that we need to address in our marketing. So local stories, funding, the data component, and what are our musts and what are our needs, and what are some things to consider, not necessarily the how and what it would look like, but the things that we really, the ingredients that we need to have a successful communications plan for next year.
This is Mary, and what I would say about funding and local versus state is that currently there is no program that is fully funded by the state money. And so I am always talking to our board about what their funds go towards that is supporting programs that the state wants us to do but doesn't support, or that we've chosen to do and doesn't support. So I feel like that has to really be part of the conversation too, is, you know, what is the health department's role and what is the board's role in what they feel is important to support. And that's kind of our position, is we keep saying these are what's important to us.
Great, that's helpful. And Jamie, great idea. I think that can help shape up the steering committee agenda item on this topic for March. And I'm going to wrap us up here to be respectful of people's time. Great conversation, you guys. Really helpful, and I look forward to the next one like this. So stay tuned.
Hey,
we'll bring you more. And yes.
Hey, Marie. This is Scott. Could I get Alan and Jamie to stay on for a minute? Can you guys do that?
Sure.
It's a totally separate issue.
Anything for Scott.
Okay.
Okay, I am going to stop the recording on the webinar and dismiss the technical work group. And thank you guys. We'll be in touch with you soon.